Just because you cannot see it doesn't mean that it isn't real. Can they really believe the pain that I have that they cannot see?
I didn't have a clue. All I knew was I had this strange condition called psoriatic arthritis. I could no longer play football, I could no longer do sport. And I was thinking, wow, is this the end of my life? What do I do now?
Working and living with axSpA is very hard because every time I wake up in the morning, it's very hard for me to get up to go to work.
The biggest area of my life that spondylitis has affected has been my work. I lost my career.
I got to a point where I was stuck solid in hospital on morphine, and I was in a really bad state, and all my dreams had gone out the window. I was finished.
I do not want to feel that I am burden to others.
My fear with my relationships with my children is that one day I may not be able to run around with them like I do now every day.
I would be lying if I said that I haven't thought of terrible thoughts to end the pain.
I think a lot of the time it really feels like words don't always translate to what pain feels like.
Ladies and gentlemen, very warm welcome to this symposium entitled Making the Invisible Visible. And please be assured this will be not about corruption or political faults, but rather about musculoskeletal diseases, and we will get insights into pathophysiology and normally invisible processes in rheumatic conditions, mostly in axial spondyloarthritis and psoriatic arthritis. Here you see the obligatory disclosures. There are some housekeeping notes. First, recording should not be performed here. There will be, after first two talks, a Q&A session and a panel discussion. The particular feature of this symposium will be that questions will be taken only virtually. So if you would like to ask a question, please scan via EULAR app the QR code you see here and you see on other screens. And then in the app you will have a possibility to ask a question. The questions will be pre-moderated and selected by the moderator. And then at the end of the symposium, we will have a second round of Q&A and discussion. There are some learning objectives I mentioned already. We want to see most recent advances in the area of axSpA and PsA. My name is Denis Poddubnyy. I'm one of your co-chairs for today. We have Georg Schett from Erlangen, Germany, as a co-chair and a speaker. And we have Raj Sengupta from UK and Maria-Antonietta D'Agostino, designated speakers for the second part of the symposium. So at this time point, it's my great pleasure to invite Georg Schett to the stage to give the first talk on how to visualize inflammation tissue response in PsA and axSpA. Georg.
Yeah, thank you, Dennis, for the kind introduction. Ladies and gentlemen, good morning. So I have the basically task to give you a short overview on imaging in spondyloarthritis and PsA, especially first starting with bread and butter concepts and then having some new imaging techniques presented here. These are my disclosures, and it starts actually that PsA and axial spondyloarthritis are very different from rheumatoid arthritis. It's often not possible to see swelling because enthesial structures are involved. And therefore, actually, diagnosis is often cumbersome because it's only related to pain, and therefore imaging is very much needed. And here you can see basically that enthesitis is actually an inflammation of the outside the bone at the insertion side of the tendon, and osteitis. Osteitis is actually a domain of MRI, and the outside of the bone, of course, you can see with MRI and with ultrasound. And these are the key two imaging technologies, and we hear from that later by Denis and by Raj and by Maria-Antonietta how they are used. The other important part in the disease is that the enthesitis leads to substantial tissue responses which impair the quality of life of patients. That happens in the axial skeleton, like in axial spondyloarthritis with syndesmophyte formation, and Denis will speak about that later, but also in the peripheral skeleton, like, for instance, calcaneal spurs and Achilles tendon spurs. This image actually in the right side was provided by Peter Herz, a dear friend in Munich, and you can basically see very nicely that even in the conventional X-ray you can distinguish PsA very nicely from rheumatoid. There is this fluffy appearance of the periosteum here and here and here and here, which is a typical feature of enthesitis at the classical joint. It's not an intra-articular process, an extra-articular process with inflammation of the periosteum and later bone responses. Now, this is very important because over time, tissue responses progress and lead to impairment of function, which is both involving the axial skeleton with this classical imaging of axial spondyloarthritis, or AS in this case, in the left, but also in PsA, where you basically see at the right-hand side that there is a massive osteoproliferation happening in the joints, and this gives the typical feature when we palpate joints of PsA patients with a bony swelling, sometimes resembling features of osteoarthritis. Now, why is this important? Why imaging is important? Well, we have a lot of cool treatments now to abrogate inflammation, and we have learned a lot how actually which cytokine inhibitions are working in PsA and axial spondyloarthritis, and you can see psoriasis, psoriatic arthritis are in this branch with IL-17, IL-23, and TNF, which is a common root of these diseases. And axial spondyloarthritis is a very 17 TNF-driven disease, as you know. Now, why is imaging important? There are 3 points. As mentioned, often there is no swelling because it's enthesitis, so one has to rely only on pain, and obviously pain is very heterogeneous and it can be inflammatory, non-inflammatory, and therefore imaging to basically check for inflammation is important. The second part is that we cannot always rely on C-reactive protein, which is often absent in psoriatic arthritis and spondyloarthritis, because there is not a key role of interleukin-6 in the disease. And finally, there are sad tissue changes in PsA and axial spondyloarthritis, which can be picked up with imaging, and we will hear from that later. So the 2 key technologies are ultrasound, and Maria-Antonietta D'Agostino will speak about ultrasound. It's the detection of a power Doppler signal, for instance, here in the Achilles tendon, showing actually inflammation. And obviously, ultrasound is also able to detect tissue responses. Ultrasound is not very good in the spine. It's not very good for osteitis, should stand there, but it's also not good for the spine. And you may prove me false, Maria-Antonietta, but ultrasound is not always the perfect thing. MRI is working in peripheral and axial disease, but there are actually downsides and upsides of both technologies. MRI is pretty cool because you can detect osteitis. This is just one image of Achilles tendon enthesitis, where you see basically the outside inflammation, water enrichment, and also the inside inflammation, which is osteitis, and in between the bone lamella. So it allows to basically give a comprehensive picture of the disease process, and we use that sometimes to basically detect inflammation. MRI, this is from the Berlin group, is also sometimes very helpful to look at the global picture of inflammation and show that there's a composite of axial and peripheral disease. As you see here, there is inflammation in the spine. At the same time, there is enthesitis at the shoulder, the trochanter, and the knee. So it gives whole body MRI a comprehensive picture of inflammation, but that's actually reserved to specific centers. MRI and ultrasound allows to define a group of psoriasis patients with high risk to develop PsA, as you see here, when there is inflammation present, as you see here, and pain present. the progression to psoriatic arthritis is very high, and that allows in the future early intervention. And this is one example for early intervention in psoriasis patients with secukinumab, where you can see that the drug can actually wipe out these enthesial lesions here in the wrist joint and in the MCP joint, and also improve pain, the global VAS and the PsA, which is a quality of life instrument in psoriatic arthritis. So early detection of inflammation in psoriasis is possible, is feasible, and early intervention is also feasible. Now, these technologies are usually picking up inflammation, but the quality of the process is not very well picked up. There are other technologies that's near-infrared imaging, where you basically inject a dye, which is indocyanine, and then you basically look at the emission of light after stimulation. And basically here is the red parts are actually highly vascularized lesions in the joints, but also in the skin in a patient with psoriatic arthritis. So that's a rather feasible technology, which is, I think, growing in the future. And then there are more sophisticated tools to actually not to use a biopsy of the joints, but actually to look at the molecular profile in the joint by non-invasive method. That's the so-called MSOT technology, which is called multispectral optoacoustic tomography, where you are able actually to look at oxygen saturation, hemoglobin levels and collagen levels and lipid levels in joints. And in the left, you can see synovitis. In the right, you can see enthesitis, and there are remarkable difference. For instance, oxygen consumption in synovitis is much higher than in enthesitis, but vice versa, collagen content is increased in enthesitis, reflecting actually this tissue proliferative responses in the disease. So we are actually on the way to understand the molecular process and the difference in molecular processes, synovitis and enthesitis, by non-invasive imaging technology. The second part of the disease, and we will hear from that later, is actually tissue responses. As you see here, I mentioned that these are the enthesiophytes which form in a patient with psoriatic arthritis, and that's a very dynamic process that can happen within a few weeks. Obviously, what we want is to understand that better. And there is a technology which is borrowed from from oncology to actually assess tumor stroma activation. And basically, what you can do, you could use a tracer against fibroblast-activated protein, which is actually labeling activated fibroblasts. And this is extremely effective in spondyloarthritis and in psoriatic arthritis. There's a nice poster at this EULAR. You can see basically tissue responses in the knee joint, in the supraspinatus tendon. This is dactylitis, as you can easily recognize, and this is Achilles tendon enthesitis. So it allows you to separate inflammation from tissue responses. You can see, for instance, that's very effective in psoriatic arthritis in the peripheral joints. Here is actually the VAS pain scores in patients with psoriatic arthritis, and you can see basically the higher the activity of the disease, the more there is tissue responses detectable. You can also use that in the sacroiliac joint. As you see here, you walk through the sacroiliac joint and you can see this fibroblast activation spot in the sacroiliac joint, which is actually the preceding ankylosis of the sacroiliac joint. That's not inflammation, that's purely tissue response, which is pretty interesting. And also we see that there is a very strong association between disease activity as measured by ASTAS and this fibroblast activation in the joint. So it allows you actually to have new possibilities to detect tissue responses on a much more dynamic way. This FAP pad is also responsive to change. As you see here, that's baseline and after IL-17 blockade, and baseline and after TNF blockade in axial spondyloarthritis patients. And you can basically see that that cytokine inhibition also abrogates these tissue responses, which is probably very important because it has structural effects and prevents the progression of syndesmophyte formation, but also enthesiophyte formation in the periphery. Now, to sum up, what I wanted to share with you is that ultrasound and MRI are mainstay imaging technologies. for detecting inflammation and treatment responses in PsA and axial spondyloarthritis. There are new technologies underway which are able to measure vascularization and the metabolic profile in the joints and in the entheses. Then there is high-resolution CT, which allows the visualization of anabolic bone responses in PsA and axial spondyloarthritis. And finally, there are new PET technologies which allow basically to segregate inflammation from tissue responses in the disease, and actually probably allow to do much shorter trials and much smaller trials to look at the effect of certain drugs on the tissue response. At the end, I want to thank the collaborators, Andreas Rami and Christina Bergmann, who's doing FAB-PET, and also Jörg Distler, and the people who from the nuclear medicine who were involved, especially Christian Schmidt-Konz and Thorsten Kuber. Thank you for your attention.
Thank you very much, Georg. We will continue directly with the second presentation on disease modification in axial spondyloarthritis. What does the future hold? Here you see the disclosures, and I would like to start with an assessment of structural damage in axial spondyloarthritis. First, radiographic sacroiliitis. It was for years a cornerstone of the diagnosis, and it's still used to classify patients, especially in clinical trials, into radiographic, non-radiographic, and there are even studies assessing a progression of structural damage in sacroiliac joints over time. But you all know how unreliable this method is, especially if assessed by different investigators locally. Then you cannot really say whether it's grade 1, already grade 2, or maybe it's already grade 3. So it's a little bit better for the spine, where we have the EMSA score. Here the reliability of the assessment is quite good, but the issue with the EMSAs is probably we assess only a small part of the structural damage occurring in the spine. Because here we look only at anterior corners of cervical and lumbar vertebrae, so we completely ignore lateral segments, posterior segments. We ignore other structures like facet joints, costovertebral, costotransversal joints. So we believe that EMSAS is a good proxy for the structural damage in the entire spine, but it might not be true in all the cases. So what we will have in the future? We certainly will be using more and more advanced technologies, cross-sectional technologies, depicting better in a reliable and valid way the entire spectrum of changes in sacroiliac joints in the spine. Here you see an example from the CIMAC study showing you two MRI sequences and one CT sequence. And the question is whether we can assess reliably and validly structural changes using MRI. The conventional, so-called conventional sequences like STIR and T1, they have limitations. Because if you have a lot of sclerosis, it would be really difficult to differentiate between erosions and sclerosis as depicted in the bottom line of this slide. You see a lot of dark signal. It's hard to say whether there are erosions there are not. And that is why for years we had CT as a gold standard for depiction of structural changes in sacroiliac joints, but it is also possible nowadays with MRI if you use so-called cartilage-sensitive or erosion-sensitive sequence like WIPE or gradient echo sequence. You see a perfect contrast between bone and cartilage, and this is something that is useful for both for daily clinical practice but also for clinical trials. Another recent development is a synthetic CT, so CT-like images derived from MRI with the help of artificial intelligence-based reconstruction. You see here B and C. One of them is a conventional CT, and another one is a synthetic CT derived from MRI. And to be honest, probably you don't see major differences there. So B is a real CT, and C is an image derived from MRI. You have a really great depiction of structural changes there. For the spine, we will probably also utilize more and more CT, and especially low-dose CT. Here you see an example of so-called CIAS score, so CT-based score for the assessment of structural damage in the spine. And what you see here, if we ignore thoracic spine, for example, as we do with the PsA score, we're missing a lot of structural damage. We're missing really many syndesmophytes occurring in this area. And as I said, with PsA, we evaluate normally only anterior portion, but syndesmophytes, they grow in the entire vertebral body. They can be lateral, they can be posterior, and CT scan, low-dose CT scan is a valid method to assess those syndesmophytes. PET-CT has been mentioned already. This is another potential possibility to depict both active inflammation and structural damage, and our hope is that with a depiction of tissue response, of mesenchymal response, we would be able to capture also the stage between newborn formation and inflammation, something what is not really possible nowadays. Yeah, here you see another example of PET imaging, PET studies, and in this study it was very interesting to see that after successful suppression of inflammation, there was still persisting PET signal in the spine, most likely indicating active process of bone repair in those areas. What about prediction of structural damage progression in axial spondyloarthritis? The issue is we have a variety of outcomes. We have patients remaining on a low level of progression, remaining without syndesmophytes for their entire life, but we have also patients progressing very rapidly, developing within a short period of time, short in axial spondyloarthritis, 5 to 10 years, complete ankylosis of the spine. And we certainly want to identify those patients early, and of course, at the next step, we want to prevent structural damage in those patients. There are several studies which have identified the major risk factors for progression. And these are early syndesmophytes. So if you see a patient already with a syndesmophyte, you know that probably there will be more syndesmophytes in the future. This is high inflammatory activity, elevated CRP, and this is smoking in patients with axial spondyloarthritis. So the question is whether we will have more precise predictors of progression, biomarker, genetic factors, or maybe imaging. One of the new things I would like to bring to your attention today is a genetic determinants of inflammatory response and also of newborn formation. This is related to the fibrinogen and factor 13 system. We have a genetic determination of the density of the fibrin cloud. If the person has a very dense fibrin network, then the inflammatory response is rather low, and with a loose fibrin network, we have high intensity of inflammatory response, and we investigated this also in the context of structural damage progression in patients with axial spondyloarthritis. And what we could find out here, that in patients with so-called wild type of one of the genes determining the density of the fibrin cloud, the predictive value of CRP was very high, as reported previously. So higher level of CRP meant in those patients more structural damage progression. But we had also in this cohort about 1/3 of patients with an alternative allele in this gene. And in those patients, we could not predict structural damage progression in the spine by CRP. So in those patients, systemic level of CRP had no value as a predictor of structural damage progression. We need to keep this in mind, especially for future clinical trials, stratifying, identifying patients with high risk of progression. So what about prevention or retardation? What is clinically relevant for rheumatologists? You remember probably all these data coming from very first trials with TNF-alpha blockers that showed that there is no substantial retardation of new bone formation within the first 2 years of treatment. It was not easy to understand and to explain those data because we postulate there is a direct connection between inflammation and new bone formation in patients with axial spondyloarthritis. So what was the reason for this? Yeah, there are several reasons. Well, one of them, probably 2 years was too short. And second, we had already very advanced patient here, so patients with 15 years of symptom duration with a lot of structural damage in the spine, so it's logical that for a certain period of time, progression went further. There are some data showing that this is probably true. First of all, these data from North American cohort that showed that initiation of treatment within the first 10 years of symptom duration, that is not very early, but still better than afterwards, is associated with less progression as compared to late initiation of anti-TNF treatment, or probably this is true for any effective anti-inflammatory treatment. Then there was very nice work from Swiss cohort that showed that if you achieve, as a patient with axial spondyloarthritis, remission, so low level of ASDAS below 1.3, there will be no new bone formation, no structural damage progression in the coming 2 years. And finally, most recent analysis from the GASPIC cohort, we could demonstrate that the effect of TNF-alpha blockade on structural damage progression is not immediate. And this explains very well previous negative results. Here you see what has happened within the first 2 years after anti-TNF treatment initiation. There was no difference between users and non-users of TNF-alpha blockers. But if you look in the following 2 years, so after 4 years, then you see a clear difference. So this effect, if you start a treatment today, you will observe the difference after 4 years, and this is most likely related to this intermediate step of repair and beginning new bone formation that takes time, around 2 to 3 years. There is, of course, a need and a wish to be able to stop new bone formation immediately, right away. You start the treatment, you control inflammation, you control new bone formation, and potentially there might be a role for IL-17 blockade in this context. At least animal models indicated that there might be immediate effect also on osteoblastic activity in this B27 transgenic rat model of the disease. And we also know from clinical trials with IL-17 inhibitors that in comparison to earlier studies where we had 60% of patients with radiographic spinal progression, in these studies, here you see data for secukinumab, only about 20% of patients progressed at all after 2 and 4 years, and the same was also true for ixekizumab. So there was an indicator that the rate of progression under treatment with IL-17 blockers is lower as compared to historical data with TNF-alpha blockers. So the question is, what do we expect in terms of prevention and the retardation of structural damage progression, especially in high-risk patients? So first, results of the CONSOL study, probably you heard that. We see an effect of additional NSAIDs, but in this study it was not statistically significant. Another important and interesting study, this is a first head-to-head study in the area of axial spondyloarthritis, where we compare the effect of secukinumab versus adalimumab in terms of structural damage progression. This is a primary endpoint, and in terms of clinical efficacy, and the results of this study are expected this year. So I summarize here, imaging techniques are important to assess structural damage and disease progression, axial spondyloarthritis, with a range of novel modalities under evaluation. There are some genetic determinants which might affect the prediction of structural damage progression in patients with axial spondyloarthritis. Effect of NSAIDs on structural damage progression is quite variable in different studies, and we expect this year the results of the SURPASS study, where we will see whether immediate inhibition of structural damage progression would also be possible. Thank you very much for your attention, and would be happy to take questions.
Yeah, thank you very much, Denis, and I will start the discussion and hand over then to Denis because he can cool down a little bit, right? So the first question to Denis is, from a practical perspective, what will the results of the SURPASS study be of relevance for patients with axial spondyloarthritis? Maybe you can comment on that first.
Yes, absolutely. I think it depends a little bit on the outcome of the study, but irrespectively whether or not we will see the superiority of secukinumab over adalimumab, I think we'll get very important information on comparable efficacy of those drugs. So if the primary hypothesis is true and we see less structural damage progression associated with IL-17 blockade, I think it might have clinical relevance, especially for patients with high risk of progression, so patients with already presence in desmophytes in the spine, patients with high CRP with a lot of inflammation in the spine, in order to prevent structural damage while one would take the drug with proven efficacy, not only clinically, that is more or less clear, but also in terms of retardation of newborn formation.
Yeah, thank you, Denis. And there is another question which I probably ask before I hand over the iPad to you, and it's probably to Maria-Antonietta and Raj. The question is how important it is when there is a risk constellation for structural progression to start biologic therapy early. Maybe you can give short views on that.
Yeah, so I'm actually going to talk about that in my talk. So I'll say that in more detail. But essentially, for me, I would use these prognostic factors in clinical practice. And if they're there, I'm quite aggressive with my treatment of these patients. I don't want to send them off with anti-inflammatories for a year and come back. It's going to be too late. So I'm quite proactive in identifying those patients.
I would just add that if you can see inflammation wherever, even peripheral, and I think that this is a marker of high disease activity, and probably to prevent structural damage is important to start early.
There is a lot of interest around the novel technique you presented. So FAPI-PET, this is something new, so people are really excited about this. So depiction of mesenchymal response. So what is your personal view on this? Where do you see the role of this modality in the future? Is it a research, or maybe we can find a place also in clinical routine?
Yeah, well, it takes always time with a new technology till it's in clinical routine. In principle, feasibility of PET-CT in clinical routine is there. We think of, for instance, giant cell arteritis. I think it's more a single shot imaging approach where you basically look at the overall patient and the overall burden of tissue remodeling, and that's a pretty interesting approach. So it's a single shot imaging, and then it's much more feasible, of course. So in principle, I think it's feasible, but implementation of new imaging technologies in the clinical practice always takes time. And of course, this is a technology which is always linked to a clinical center and cannot be done in private practice.
Great, thank you. There is nowadays also a lot of interest in terms of IL-17 blockade, and especially different types of cytokines. So the question is probably to all of you. So what do you think about IL-17A versus IL-17F blockade, maybe even broader blockade with a receptor, whether it has any clinical relevance or might have clinical relevance?
I mean, I think when in clinical practice nowadays, when we're treating our axSpA patients at least, we tend to select the biologic based on the extramuscular skeletal manifestations. So if someone's got bad inflammatory bowel disease, we're probably going to avoid an anti-IL-17 and head more towards something like adalimumab, and simply with uveitis as well. So I think separating anti-TNF and anti-IL-17 we're quite good at in clinical practice. My reading of the anti-IL-17 data, between bimekizumab, ixekizumab, secukinumab, I think it's a little bit harder to tease out the clinical difference between those drugs. But I just wanted to add to Denis's point around the SURPASS study. For me, what might be interesting is whether IL-17 will act quicker than anti-TNF in terms of radiographic halting, and there are hints of that already. And I think if that is the case, it's going to be very relevant for our patients, because particularly those high-risk patients, we don't want to wait for 4 years before we see that inhibition. We want to see it quickly with IL-17.
And I think that they will also teach us about the pathway that we have really to target in this kind of patients.
What is your view on this?
Yeah, I think, well, we have to wait a little bit. I mean, the 17AF inhibition by bimekizumab has good data, right? And whether this actually is then making a superiority over currently existing interleukin-17s, we don't know. But I think it's important to have this drug available that enriches the armamentarium in PsA and axial spondyloarthritis. I mean, to your point, the broader you inhibit IL-17 to pathway in general, the better you are, is actually falsified by brodalumab, because the brodalumab data, which actually inhibits the receptor and more than one IL-17 isoform, was actually not that good. So I think it's really about what kind of cytokines you target. Obviously, AF inhibition is working well, but I think it's not a general concept. The broader you are, the better you are.
Yeah, and we will probably also need strategy or head-to-head comparisons in the musculoskeletal area. That is not the case right now. Maybe a final question, again related to FAPI-PET. The signal, what you see here, how specific is it for inflammation or newborn formation related to immune-mediated disorder as compared to degenerative changes, for instance?
Yeah, well, it's extremely specific for tissue response. So basically, when you have inflammation is not picked up. It's only the tissue response picked up. So you have, for instance, when you do FDG-PET in addition, you see actually completely negative lesion where you have tissue responses. Of course, tissue response is triggered by inflammation, so you have also mixed lesions. But the tracer is absolutely specific for the tissue response. But it doesn't matter which kind of tissue response. Wherever there's tissue response, you pick it up. So it's also scleroderma, it's, for instance, IgG4 syndrome, and it's also like spondyloarthritis and PsA. So that's it's unspecific with respect to tissue responses, but it's specific as compared to inflammation.
I would add that if you have pain and you make a FAPI-PET, you know what is the moment of the disease, if it is the inflammation or if it is the moment of the response. I think that this is the picture that permits to you to see at which moment you are in the story of the inflammation and the repair.
So as always, a rheumatologist should be absolutely clear what the disease is at to assess the response.
I would think so, yes.
Okay. Yeah, I don't see any further questions. Thank you very much for the great discussion. So we can move to the second part of our symposium, and it is my great pleasure to welcome Raj Sengupta, who will be talking about how does structural damage progression impact patients. Thank you very much, Raj.
Okay, thank you, chairs, Georg and Denis. And I'm going to spend the next 10 minutes or so talking about how structural damage progression impacts our patients with axial spondyloarthritis. So here are my disclosures. So I want to go through this with a case. This is a patient called Miss A. She's 35 years old. She's had inflammatory back pain, and much like these patients present in early disease, they follow a flare pattern with their backs. The pain will come and the pain will go, unlike the mechanical spinal patients, which seem to have more persistent pain over time. She's now unemployed. She's a smoker. You can see her x-ray showing bilateral grade 3 sacroiliitis, and she gets a diagnosis of radiographic axial spondyloarthritis some 7 years after the symptoms started. These are patients we're seeing in clinic all the time, and patients will come and say they're frustrated, their mood is low, they have chronic sleep problems, and fatigue is a major issue. You can see that she has high CRP of 15, her disease activity is high with a BASDA of 7 and an ASTAS over 4, back pain score of 8, and quality of life poor with a score of 14. And this is an unusual. Miss A represents patients we see all the time, and the research literature also supports this. So when Carl Gaffney and I looked at this a few years ago and we published on it, There were 1,200 patients in this study, 800 with radiographic disease, 400 with non-radiographic disease. If you look at the cohort overall, you saw an 8.5-year delay in diagnosis. But when we took the more recent 5 years between 2009 and 2013, whilst we were diagnosing 50% more patients, the delay in diagnosis, or the mean delay in diagnosis at least, was worse at around 9.4 years. The median in this study for delay in diagnosis was 5 years. And this does impact on the patients, and we see this in this nice systematic literature review that was done a few years ago. And if we look at the delay in diagnosis for those who are over 10 years, 41% of these patients were unemployed compared to only 20% who had a delay in diagnosis less than 4 years. If we look at employability, a great number of patients, over 90% of patients, have their employability impacted. And for me, again, in clinical practice, I do believe that employment or unemployment is a window of opportunity, and if we intervene in the right patient at the right time, we can really prevent the natural progression and evolution of unemployment. So it's not just unemployment, there's also disability, and by that I mean physical function and mobility. And the systematic literature review shows a greater number of studies showing significant negative impact of a delay in diagnosis on physical function and PsA. Coming back to our patient, then, Miss A, we can see that it impacts her daily life. We can see the cervical spine involvement on her radiographs, and she talks about difficulty in driving because she can't look over her shoulder. She has difficulty in getting dressed. Coming back to the disability side of things, her physical function is moderately impaired with a BASFI of 5, and a PsA is really, for me, quite significantly impaired at 5.6. Her FACIT score measuring fatigue, remember, FACIT is a score between 0 and 52, and the higher the score, the better your fatigue. Again, moderately impaired at 25. Denis has shown you how the MSAS is scored, and she has an MSAS of 24 out of 72. Now, Denis has touched on this as well, but for me in clinical practice, this is an issue. So we know that if we look at radiographic progression here from the OASIS cohort, the progression at the cohort level is quite linear. It's about 2 units over 2 years, of 1 unit per year, and we can see this over the 12-year time point. But as Denis alluded to earlier, at the individual patient level, there's huge heterogeneity. We have some patients in the bottom right who show no progression. We have some patients who show linear progression, and I do worry about these patients because the rate of change is so slow, the clinician and the patients can miss that radiographic progression over time, mainly because the patient can accommodate to it so well. But again, as Denis said, the people on the left are probably our biggest worries. It's rapid progression, huge progression happening quite quickly. And what we don't want to do is send these patients off for a year with an anti-inflammatory and come back, because again, we're going to miss that window of opportunity to intervene. So how might we identify these patients earlier? The research gives us some clues. Here, again, from the OASIS cohort, we see the men will progress more than women. HLA-B27 positive patients progress more than those who are negative. And if you have radiographic damage at baseline, again, you're much more likely to progress. Another very important parameter is CRP, relevant for Miss A, whose CRP was elevated at 15. And if you have a raised CRP, you have a 4-fold increase in radiographic progression. Now, Maxime Dugados's study from back in, I think it was 1999 or 2000, showed that for axSpA patients, only around 40% of patients have a raised CRP. So whilst it's not terribly helpful, when it is raised, I really take note of those patients because I think I probably should intervene if clinically appropriate. So I've talked about those parameters. We can, and Denis showed you this as well, but we can start putting some of those parameters together with matrices such as this. This is now a decade old, but very relevant in clinical practice. What we see is if a patient has a raised CRP, if they're a smoker and they've baseline syndesmophytes, more than 50% of those patients will get a worsening of radiographic progression over 2 years. The story around disease activity is also highly relevant, and data here from the GESPIC cohort showing us that if we leave our patients in high disease activity, so an ASDAS of more than 3.5, the mean MSAS change was 1.73 units compared to those patients in low disease activity where the rate of change was only 0.59. Again, looking at this in a different way, of patients who have a more than 2-point progression over 2 years, the patients in high disease activity, 25% of those patients showing that worsening over 2 years compared to the low disease activity patients where only 13% of patients progressed. Now, understanding the relationship between structural damage, disease activity, function, and mobility is complex. We can see that if a patient has a lot of structural damage, it's quite obvious that they're going to have quite bad function and mobility impairment, but that relationship in earlier disease is much more difficult. This is data from the GESPIC cohort. These patients had under 5 years of disease. They had rather a low amount of radiographic damage. Most of them had an MSAS score of 24 or below. And what we saw is if you look at the comparison of the rate of change in the MSAS and BAS-Phi and the rate of change with MSAS and BAS-Mi, there is a very weak relationship such that you need an increase of 20 MSAS points to be responsible for 1 increase in BAS-Phi point. And an increase of 12 MSAS points that would be responsible for an increase in 1 BAS-Mi point. So patients can, at least in early disease, can accommodate quite a lot of radiographic change before they have an effect on function and mobility. And in fact, in this study, the strongest relationship was with disease activity, which makes sense then to target in our early disease patients. Coming back to Miss A, then, we saw that she's a smoker. She has a high CRP. Her disease activity was high. She has functional and mobility impairment, and she had 2 anti-inflammatories, and we decided to treat her with a biological DMARD. And for a patient with relatively established disease, these are the improvements I would expect to see. Her BAS-Di and BAS-Phi improve to a score of 4. With biological DMARDs, we don't see massive improvements in BAS-Mi, particularly in patients who have BAS-Mi scores at this level. For me, it's the combination of the biological DMARD and help from our physiotherapy colleagues. The combination of that is likely to achieve the greater improvement. We don't see an improvement in an MSAS score as shown. So I've talked about predictors of radiographic progression. What about predictors of response to biologic therapies? And I'm showing you results from this meta-analysis, which looked at BAS-Di 50, the ASAS 20, ASAS 40, and BAS-Di. And from this meta-analysis, we see that CRP was the best at predicting all of those outcomes, with B27 positivity coming in a close second. Younger age, male, gender, lower BAS-Phi, and higher BAS-Di do also predict these, but only for the BAS-Phi, for the BAS-Di 50. And again, coming back to this disease duration story, which I do think is important, we are going to have the best impact on our patients if we treat them in early disease. And this is shown by these 4 large clinical trials of etanercept 50 milligrams a week, where if you treat patients who've had disease for 10 years, only 1/5 of them achieve partial remission, whereas if you treat patients earlier, 0 to 2 years of disease, just over 1/3 will achieve partial remission. If we want to look at the BAS-Di 50, and this nicely brings in the relationship with CRP and disease duration, we know that CRP will predict response to biologics, but if you treat these patients later on with 25 years of disease in blue, you see that the response or the chance of getting BAS-Di 50 is not as good as if you treat them earlier on. And for me, when patients come in and say, I want to leave these drugs till I'm really bad, I want to try other things first, in the clinically relevant and appropriate patient, I have that discussion about let's get you on this treatment straight away because we're going to get the best clinical outcome and the best radiographic outcome for you. This is also shown in the measure studies where if patients had more than 10 years of disease, you only saw ASTAS inactive disease, so that's an ASTAS less than 1.3 in 10% of patients, and it was double the number if they had less than 1 year of disease. If you look at the BASDAI 50 by the patient's age groups, again, it's the younger patients who are more likely to achieve a BASDAI 50. Just a couple of slides on psoriatic arthritis and looking at the relationship between disease activity and structural damage from the Go Reveal study. And here you're seeing disease activity with the DAPSA, and the higher the DAPSA, the greater functional impairment as measured by the HAC. If we look at the radiographic damage, an interesting story here between those who are in remission and those who are not. And you see that as the modified Sharp-Van der Heide score increases, you have greater functional impairment, but those who are in remission are not as badly affected. And corresponding data from the Future 5 study with psoriatic arthritis showing patients who are in sustained DAPSA remission, and this was defined if they had the same response at least 2 out of the next 6 visits, which happened every 8 weeks. And what we see, the patients who are in sustained DAPSA remission have the greatest change in their physical function scores. Similarly, the patients who are in sustained DAPSA remission also show the greatest proportion of non-progression, and it is quite similar to those in DAPSA remission at 1 instance as well. So to summarize my talk, a delay in axial spondyloarthritis or psoriatic arthritis diagnosis, hopefully I've shown you, does severely impact our patients, resulting in poor mobility and function and increasing their chance of disease progression. If, sadly, there is that irreversible structural damage, this leaves the patients with axSpA and PsA in constant pain, adversely affecting their physical function and quality of life. There are several patient characteristics and clinical factors that we potentially could use in routine clinical care to identify these patients who are at most risk of progression, identify the patients who are most likely to respond to the biological DMARD, and thereby prevent radiographic progression for them in the longer term. Achieving and sustaining low disease activity does improve outcomes for our patients with maintaining physical function and reducing structural damage progression. And I've shown you with Miss A, who's the patient of ours, experiencing a reduction in disease activity and improvement in function when she was treated with biological DMARDs, but really, I wish I'd met Miss A before and intervened at an earlier stage with a biological DMARD, because I would have been more likely to get remission for her and a better long-term outcome where radiographic damage is concerned. Thank you.
Yeah, thank you, Raj, for this very practical approach. I really appreciate. And the next speaker, we go actually directly to the next speaker before we enter discussion, is Maria-Antonietta D'Agostino from the Catholic University in Rome. And she will speak about the latest insight on ultrasound in mostly psoriatic arthritis, I guess. And it's a pleasure to have you here, Maria-Antonietta. And I also ask the audience to type in questions to challenge the 2 last speakers, because you challenged us before, Denis, so also the second 2 speakers have to be challenged adequately. Maria-Antonietta, the stage is yours.
Thank you, chairs. Good morning, colleagues. We started speaking about how to make visible the invisible, and I think that we are concluding this journey really to try to see how we can visualize at the moment what it is the inflammation psoriatic arthritis. These are my disclosure. We have heard that the most important unmet needs in the challenges that we face every day in psoriatic arthritis, and I will speak now about psoriatic arthritis, is the delay in diagnosis that is so important as it is important in axial spondyloarthritis. And we know also that by different study, clinical study, ultrasound study, that the structural progression, the peripheral structural progression is linked to synovitis and enthesitis. And we want always to know when we have patients with psoriatic arthritis that can be characterized by different phenotypes, what is the prediction of response to a treatment. I would just show you this picture that I love to show because I think that ultrasound is the technique for evaluating at the moment what happens in the peripheral joints, inside the joints, outside the joints, in patients with psoriatic arthritis. I think that using power Doppler, so the color, the visibility, we can really visualize what happens in our patients. And another thing that I would like to say that you have seen how beautiful are the pictures, but one of the main comments that we receive as ultrasonographer is you are not reliable, you are not standardized, is an operator-dependent techniques. And what we show that we have developed over the last year, believing in this technique, a reliable ultrasound scoring system that is able to visualize the synovial hypertrophy, so the morphological abnormalities that we squeeze with our joints, and the presence of an inflammation of within this tissue, which is the power Doppler, which is the vascularization, that may, I would say, correspond to other serological marker of disease activity. Putting together these two components, we can really cover the inflammation of all the joints in psoriatic arthritis. We have also tried and obtained to make visible what it is the enthesitis. Already Georg told us how it's difficult to visualize the pain in the joints that they are not swollen. And we always believe by clinical practice that it is an enthesitis. Using ultrasound, we can visualize what it is happening in the enthesi, where is the inflammation, where is the structural damage, and what is the pain, the cause of the pain. And in that case, with Inomeract, we have also graded the presence of an enthesitis at site level in a way in which we can consider the B mode, the edema of the enthesis, and the Doppler, the presence of a vascularization that is so difficult sometimes to detect. So, from psoriasis to psoriatic arthritis, how we can use ultrasound? Several studies have shown that in patients with psoriasis, even without pain, it is possible to see abnormalities in the joints, in the synovial membrane, but also in the enthesis. But it is even more important to visualize this inflammation when there is pain, to discriminate if the pain is an inflammatory pain linked to a subclinical disease, telling the disease is probably already there, from another pain that can be linked to eventually structural damage. And believing so much in this technique, we perform a study that it is a really important study. It's the first study that used ultrasound, and especially the ultrasound-detected synovitis, as a primary endpoint. We really wanted to see if we were able to visualize the inflammation and to evaluate the inflammation in an objective way in patients with psoriasis. For this reason, we perform worldwide a randomized control trial, placebo control. We use secukinumab, 150 or 300 milligrams, according to the skin stance of psoriasis, in patients that were not responders, but had active active psoriatic arthritis based on swollen joints and no response to conventional DMARDs or NSAIDs, and with at least one clinical enthesitis. We examined them by ultrasound, and patients with synovitis activity by ultrasound were randomized in the two groups. So our primary endpoint was the response on synovitis at 12 weeks. Then from 12 weeks to 24, we switched the placebo to secukinumab, and then we followed them until 1 year. We also add other questions to this study, not only the response at the synovitis level, but also to confirm the study and the data that we know on the efficacy on secukinumab in psoriatic arthritis, but most importantly, to explore the possibility to use ultrasound for following enthesitis. So, you can see here the baseline characteristics of the clinical joints involved and in these patients. You can see that there were patients with a disease that has almost 6 years of disease durations. There were the classical psoriatic arthritis that you include in your study, and you see that the gloss, which is the sum of the synovitis at the joint level, was quite high, and you can also see the amount of synovial hypertrophy in B mode and the amount of Doppler signal. They were clinically active in the enthesitis based on the SPARC, and you can see that the mean number of entheses was almost the same between clinical evaluation and ultrasound. But since we didn't use ultrasound as an inclusion criteria for enthesitis, you see that not all patients had an ultrasound detected enthesitis. And so we were using B mode and Doppler at definition to try to capture the inflammation on enthesitis, or to see if we could use only the Doppler signal as a measure of inflammation. If you can see by this graph, probably we didn't have so many patients with a Doppler activity in enthesitis. If you look at the distribution of synovitis, according to the way in which we can measure synovitis, so swollen joint, tender joints, and by ultrasound, you can see that most of the patients had the wrist as the main joint involved, the knees, the MCPs, and the MTPs. And what it is quite normal, because this is the usual population that we include in this study. If you look at the distribution of the enthesitis, the ultrasound-detected enthesitis, also these show us that the elbow, the knees, and the Achilles tendon were the entheses more frequently detected, either by clinical evaluation, but also by ultrasound, telling that the elbow is something that we have to look for. You can see here our primary response. The primary endpoint was met, and we were able to demonstrate objectively the response to secukinumab, the differentiation between placebo and secukinumab starting from the first week. And you see nicely that ultrasound decreased over the time until the 12 week. And if you look at the second part of the study, so when the placebo was switched to secukinumab and over all time, we can see nicely how ultrasound is able to show the response very nicely also in the placebo, and we can follow these patients over time with ultrasound, showing that the disease was controlled. What about the enthesitis? You can see here that although it was not one of the primary criteria, nor the secondary criteria, we demonstrated a nicely differentiation between placebo and active drug in the first 2 weeks, probably not at 12 weeks, but when we switched the patients from placebo to secukinumab, also the OMERACT ultrasound enthesitis was able to show this response that was nicely seen until the end. What about ultrasound to predict the response? So we in order to try to see if we were able to identify the patients who would have respond better to secukinumab, we perform a cluster analysis on the baseline data based on the ultrasound characteristics of synovitis in these patients. What we seen is that we were able, based on the ultrasound characteristics, to identify 3 groups of patients. Cluster 1 that were mostly characterized by enthesitis, synovitis, and quite well distributed, like cluster 3. But if you look at cluster 2, was the cluster in which we detected the lower number of inflammation by ultrasound. And if you look at the response based on the cluster analysis, you can see that overall, in the first 12 weeks, we can see very well the differentiation between the placebo and control. But if you look at the cluster, you see that cluster 1, that it was characterized by big joints and small joints, demonstrated a very nice differentiation between placebo and control. Also, the cluster 3, that it was more characterized by small joints involved. And if you look at the cluster 2, that it was the cluster in which we found less inflammation by ultrasound, this was the cluster that we were not able to differentiate between placebo and control. In conclusion, what these studies tell us, that synovitis and enthesitis are a true marker of disease activity, and they are critical for cartilage bone destruction in PsA, because study demonstrated that if you do not control the disease at this level, you will have structural damage. Power Doppler ultrasound is an objective and easy tool to evaluate synovitis and enthesitis response, and we were able to demonstrate that secukinumab was really rapid and effective, starting from the first week, to demonstrate the response to the treatment, supporting the use of this drug in the pathogenesis in the pathway of synovitis in PsA, and the use of ultrasound for monitoring this. Thank you very much.
Yeah, thank you very much. I will start the questions, and thank you for the feedback also from the audience. Raj, what do you do if you have a patient with axial spondyloarthritis and the patient is in remission, let's say ASTAS below 1.3, has a normal CRP, but you do an MRI and you find actually spondylitis? What do you do then?
I wouldn't have done the MRI, Georg.
Well, let's say that some colleague would have done the MRI, and the patient comes to you in tears.
Yeah, no, and it is very difficult. So I think practically, I would treat the patient and not the test. If the patient is doing well, and I haven't got poor prognostic markers, I probably wouldn't treat the MRI on its own. I think we've also got to be careful that MRI can be due to more than just axSpA, and so we have to make sure there aren't other explanations like fractures, like patients who may be doing a lot of exercise and stressing their sacroiliac joints, that may be other reasons for it. So the patient first, and then think about the test.
I think people will love you for this.
Will they?
Yeah.
Thank you.
So Maria-Antonietta, you have a psoriatic arthritis patient and you do your famous ultrasound examination. However, the patient is in remission for whatever reason. You did the ultrasound because you like it so much, and there is no CRP. So there is a lot of synovitis present in the joints. What do you do?
It depends on the amount of synovitis. I would ask first, did you get your treatment? Because patients sometimes say, I took the treatment, they don't take. If there is 1 or 2 joints, I would not modify the treatment. But if I have several joints inflamed, I will try to discuss with the patients to understand what happened.
So you value subclinical inflammation?
This is subclinical inflammation is inflammation. So if you believe on inflammation, whatever it is the way you measure this, you have to treat.
Thank you very much. So, Raj, a question to you. You impressively showed how much is the therapeutic or the diagnostic delay in axial spondyloarthritis. How do you approach that? I mean, are there any activities in the UK to reduce that? And probably also, Denis, you can give your experience in Germany, and Maria-Antonietta in Italy. Would be nice to know that.
So, Georg, I think the situation is complex, isn't it? I mean, firstly starts with the patient or the person with back pain who maybe thinks is due to their work and not seeking help, so that's a delay. Then we have clinicians in primary care who don't see the disease very often. And then even in secondary care, sometimes we get it wrong by doing the wrong tests and not diagnosing quick enough. And I think the problem spans across all areas. In the UK, and I know Denis has done a lot of work in this regard, we've tried to build up digital tools to support the clinicians in primary care to identify patients and then send those patients on. In secondary care, we're also trying to develop new strategies to support clinicians making the diagnosis quicker. But it's a long journey. I don't think this is just about giving another talk. We have to provide tools to support clinicians who are seeing these patients to sort of diagnose or identify patients quicker and send them through to secondary care.
Thank you. Denis?
I absolutely agree. I think their awareness is a key, and we need to increase their awareness about the possibility of having inflammation as a reason of back pain among general population, among physicians dealing with those patients with back pain, primarily GPs, orthopedic surgeons in Germany. And once you think about the possibility that there might be inflammation, you won the game. Then the patient would be referred to rheumatology. We implement strategies to catch those patients early. We also tried an online tool to increase their awareness, to capture patients not covered by referral strategy. But be careful, there is another side of this coin. Seeing patients earlier and earlier means that there will be more and more patients coming to you with just back pain, with unspecific back pain, and then the question of the correct diagnosis becomes very, very, very important and sometimes really critical not to overtreat patients at the end. So these two initiatives, shortening the diagnosis but also improving the right diagnosis, they should go hand in hand.
Georg, can I just add one thing? So I think our patient organizations are very important part to play in all of this. So in the UK, the National Axial Spondyloarthritis Society, through a gold standard project called Act on axSpA, is trying to reduce the delay in diagnosis to 1 year. Really? Now, this is very ambitious, but I think by picking on lots of different facets that we've talked about and putting in strategies to address those different facets, I think it can be done. But it's the global problem, not just one thing.
Maria-Antonietta, Italy?
Italy. I think that I completely agree with my colleagues. One of the most important things and need is the education, both of physicians outside the world of rheumatology and also patients about the different phenotypes of psoriatic arthritis and axial spondyloarthritis, because people just think about joints and then only in that case they are referred to. The world of PsA is very huge, and to try to identify the right patients, I think that this is the key question.
There's an interesting question about gender difference in diagnostic delay. Any comment on that?
Oh, for sure. I think
for
that.
Sure. Yeah.
Well, I think, you know, historically, I mean, people just thought men got the disease, and sadly, there are still orthopedic surgeons, GPs who think only men get the disease. So there is a lot of education to be done. And I mean, the other one thing that I think in axial spondyloarthritis, females, you do see a bit more hypermobility for whatever reason, and sometimes that can complicate or lead clinicians away from it, which is really sad. You know, just getting that patient to bend over and saying you can bend that far, you can't have axial spondyloarthritis, is a real tragedy in my opinion.
And also the way that the pain is different in the two genders, so I think that this is something very important to take into account.
Is there progression with only B mode?
I think that we...
No power Doppler?
Yeah. In psoriatic arthritis is even more important because we are looking at big joints in which the Doppler signal cannot be so present. So B mode is another way of evaluating the inflammation. B mode is the morphological information.
There's one last question because we are short in time. I mean, there's always the typical differentiation between mechanically induced tendinitis and PsA or axSpA-associated enthesitis. Let's think about, for instance, the Achilles tendon. Any comment on that, how to differentiate? Is there imaging helpful?
I think that the people missed the talk yesterday in which we we discussed that probably we have to change the wording of mechanical enthesitis and stop to talk this enthesitis to permit to capture which are the domains, at least by ultrasound, that permit to differentiate. I think that the inflammation of the tendon is one of the key aspects of a mechanical enthesiopathy.
Yeah, so many thanks. I thank my dear colleagues for these very educative talks, and also Novartis for bringing this together, and especially you for asking so many questions. That was a really very nice symposium. I think what we learned is that when we jump into a car and go on the road, we should have some information about our surrounding. Often it's only pain that we can rely on, and imaging helps a lot to actually diagnose the disease, but also better monitor the disease. We have heard about risk factors for fast progression, I think, which is extremely important to use in the clinics to identify the patient who profit most from treatment. And I also thank the speakers for this practical approach to the topic, integrating also patient cases and a lot of interesting data. So thank you for your attention.